Well, hello and welcome to the 27th Degree with Chris and Nancy. Our guest today is Dr. Ibrahim Eid, who joins us to discuss vein health. We've had Dr. Eid on before. He's a great guest. And last time we talked about vascular disease in general, which can be broken down into arterial and venous disease. Today we're going to focus more on venous disease and vein health. But before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. I'd also like to thank Ron Gamache for our intro music and the PC Institute for producing our show. So, Dr. Eid, tell us a little bit about yourself and the Center for Vascular Diseases.
Well, thank you for having me here today, Nancy and Chris. I really love it and appreciate it. I'm a vascular surgeon, board certified. I'm the founder of the Center for Vascular Diseases that soon will be rebranded, renamed as the Center for Vascular Wellness.
Oh, I love that.
That's great.
We've been serving the area since 2002. We're currently 3 board certified vascular surgeons, soon to be 4. Mm-hmm. And we have an unbelievable team of nurse practitioners and physician assistants who make it all happen. And we currently serve Fall River, parts of the island, Aquidneck Island, Providence. We have an office in Providence, and the Taunton area. And we just started a relationship in the Attleboro area. So wow. we do cover a significant geography. We love it, and we're very proud that the communities like us and like to have us as their doctors.
That's great. That's great. Well, I think that, a lot of our viewers out there are probably familiar with peripheral arterial disease, but often venous insufficiency and venous disease is not something that we talk about as much. I think many know about varicose veins and they understand that and believe that to be merely a cosmetic issue. But obviously there's more to this than just that. So maybe we could start off by just talking a little bit about venous insufficiency and what that really means.
Absolutely. So you mentioned peripheral arterial disease. That's, in layman's term, disease in the arteries, which is the blood vessels that send the blood from the heart to the body, to the organs, to the legs, to the arms, everywhere. The veins are the blood vessels that return it back to the heart. And they get totally different kinds of diseases, so they're really not even related in terms of what happens to them. I always tell my patients with problems with the veins, the good news, I tell them this is not peripheral arterial disease. Peripheral arterial disease usually is bad news in terms of how long you're going to live, whether you're going to have heart attacks, strokes. So that's a big family of bad news diseases. While venous disease, I start by telling my patients, you will never die from this disease, or extremely rare, and you will never lose your leg from it. But it can make you miserable. It can make you not enjoy life at all. And the veins fail with many mechanisms. There's many ways a vein can fail. The most common thing you see as a physician is a DVT. They can clot. And they clot after surgery. They clot if you have other medical conditions, if you have a cancer, etc. And that's a big family of venous diseases we deal with. Typically, these are sicker patients. Typically, we see this in the hospital setting, etc. The more benign form of venous disease is what I believe we're going to be talking more about today, is what we call chronic venous insufficiency. Means it's when the veins are not insulted or injured by a clot or by an event, but they primarily fail. And the veins, you can't feel a pulse anywhere in the vein. As you know, as a doctor, you feel pulses all the time. You see it in movies. If the blood in the artery would spurt out with every heartbeat. If I open an artery now here to scare people off, I will...
and aim it to its
We won't be doing that today.
no show and tell.
The blood will shoot out
Right.
a few feet, literally. But if I injure a vein, blood will simply drip drop by drop out. And that's why we draw blood from the veins and we use them when we need to access your circulatory system, because they're a low pressure system. So the veins have very low pressure in them. But as a result of that, they have a difficult job. If you're the vein in somebody's head, it's easy. We stand up and the blood will fall down from the head to the heart where it needs to go. If you're the vein in my leg and I'm standing up, you have a problem. You have to move that blood up against gravity, and you don't have the heart pump to move it for you. So how does it happen?
Right. How does that happen? Let's explain that to the audience.
So it's two mechanisms. The first one is what we call the calf muscle function. So your calf muscles, when you move them, when you walk or just move your legs, they actually squeeze the veins, and the blood is pushed out of the area by the veins being squeezed and collapse. And the second mechanism, they have check valves. They have one-way valves. And when the blood moves up, the valve will open and the blood will move up. If it wants to go back down, which it likes to do with gravity, the valve should not let it happen. The valves would close and the blood will not go back down. So every time the muscle contracts, blood goes up, cannot go back down. The net result is blood is moving up towards the heart. So that's the normal physiology. The abnormal one is when your valves fail. We call them incompetent valves. It's like somebody has a job and he's not a good worker. You say he's incompetent. So the valves can actually, we call them, we look for incompetence in the valves.
They're not doing their job. They're incompetent.
Exactly. So what's going to happen then is blood is pushed up, goes down. The valve does not stop it. So where will it go? Well, it's going to go stay down in the leg. And it's going to be at a higher pressure now because it's pooling, it's staying there. The arteries that are sending blood to the leg, that blood needs to leave, can't leave. There will be more blood in that leg. So the blood will now go to the branches of that vein, and these branches will dilate. And if these branches are close to the skin, you're going to see them. They're going to get bigger. These veins will be bigger. They're going to bulge out. You can feel them by hand. And they're going to be under pressure.
Dr. Eid, who's at risk for this? Is it like the obese people, the people with chronic diseases? If my mom had bad veins, am I going to have bad veins?
Very possible, because hereditary is on top of the list. So it does run in families. When we meet patients with venous diseases, first thing we ask them, does your mom have it? Does your sister have it? So it does run in families. We tend to say sister, but actually it is more common in females, but men have it a lot. So this is not a disease of women. This is a disease of both sexes, but it's slightly more common in women. Now, other factors are hormonal factors. So it relates also to the hormonal cycle. So this is when women are more likely to have it. It can also be seen after pregnancy. Pregnancy creates a temporary bulky mass in the pelvis that compresses the veins for many months. The legs will be pumping, trying to get blood out across veins in the pelvis that are compressed by the uterus and the baby in the uterus. So all of these are factors that can cause it. Now, sedentary lifestyle, overweight situations definitely contribute to it. The fact that we don't exercise enough is not good. The fact that we sit all the time, that the modern man or woman, we have a tough job. We actually we sit on desks all the time. That's not what we were designed to do. We were designed to be moving pretty much, and if we're not moving, resting, to be flat with your legs flat or up. So the modern life is not friendly to our veins. and they're subjected to that column of pressure with the blood sitting over these valves for hours. If you're on your keyboard, if you're on a desk job, your veins or your valves could be more likely to fail. So it's a mix of genetics, time, aging, pregnancy, and that's the aggregate of what makes you likely to have it.
So my understanding, so there are risk factors that are present, as you mentioned, and once you start to develop some damage to the veins, it can become really a vicious cycle, right? It can worsen the situation. So now you have damaged veins, you get more swelling, maybe the pressure increases more, and then it can progress from there, correct?
That's exactly that. You gave the question and the answer. That's exactly it. Once a valve fails, it's not going to come back. So it's a mechanical failure. So from now on for the rest of your life, the blood across this valve is going to stay below the valve. And so when it dilates the veins that come out of it, it's going to be a continuous process. And that's why part of what we do when we meet people with early venous disease is education. Mm-hmm. So if I tell you from now on, you have this vein, we call them, the term we use as a late term is leaky veins. If you have a leaky vein, it's not going to stop leaking. And by the way, it's a bad term because it's not leaking outside the vein, it's leaking below the point of the valve. So that with time, that vein and more branches will dilate, and the ones that dilate will get bigger with time. And there is actually a leakage of fluid outside the veins into the tissues. And what that happens, it's you're going to start seeing swelling. So the first phase is dilated veins. We call it spider veins or reticular veins. And then when they get bigger, we call them varicose veins. Okay. But then as the disease progresses and more valves will fail, now you stress the lower valves, they're going to fail with time and more branches will get dilated. And now with all this hydrostatic pressure in the veins and in the tiny veins, you're going to have leakage of fluid and chemicals in the blood that's going to sit in the soft tissues, mm-hmm. typically under the skin. And that will cause a dermatitis that's going to irritate your skin. And the first thing we see clinically is the patients will tell us, I scratch there all the time. Mm-hmm. It itches. And that skin will start to thicken and have some excoriations, and it will start to darken as more chemicals deposit in it, and more there's more injury, more inflammation, mechanical trauma by you scratching what itches. The skin will darken in color. So typically these patients will come and they have an area typically around the lower leg, mm-hmm. on the inner side above the ankle, where they would tell me, I'm always scratching there, and look, doctor, it's turning brown. So this is signs of more advanced venous disease. And with that, there's swelling. The leg will get bigger than the other one. And the end stage is an ulceration of the skin. So typically, many patients, unfortunately, we see them just at that stage. We see them mm-hmm. just because they had a weeping ulcer or a break in their skin. That now they go to the doctor. Now the doctor sends them to us or to a wounds expert or to a dermatologist. And typically, these other professionals immediately identify it's a typical venous disease situation, and they send them to us.
So if I have a bunch of spider veins, what can I do at home before I have to make that move to see you guys? Is there things I can do so it won't advance?
Yes, absolutely. You have to look at the risk factors we mentioned. So if you have spider veins, it could be simply just local veins that become more prominent, more superficial with time. But you need to be aware of what are other symptoms that could predict that you will progress into a more severe form. So if you just have spider veins, that's fine. But if you see that actually there's swelling in my leg. That's different. Is if you notice that your leg by 3 p.m. is a little bit bigger, that's different. If when you remove your socks in the afternoon or in the evening, you realize that the area under the socks is smaller than above it, that's different. And the reason I say this is I get a lot of patients who come with a cosmetic complaint. Doctor, I hate these spider veins. Can you treat them? I heard my friend got sclerotherapy or laser or whatever. Can you get rid of them? And when I examined that person, I said, by the way, you haven't noticed that your right leg is swollen? And believe it or not, people can live for years not noticing that. I can make the audience laugh. I never noticed until I was hurting in my foot that I had, a flat foot and stuff. And when I showed it to a podiatrist in our community, he looks at me and he said, Ibrahim, your feet look like they belong to two different people. And I'm a physician. So in reality, you get people who think they have nothing, but when you examine them, you tell them it's swollen. And say, really, I've never noticed this. And one trick to find swelling is you feel the front of your leg where the bone touches the skin.
Yeah.
And in the front of the leg where the bone touches the skin, even in somebody who is extremely heavy, there is very little fat there. So the skin is extremely close to the bone in that part of the leg, even regardless of your weight, regardless of your size. So if you take your thumb and you press on that area, and then you take your thumb out and you find that there's a dent where your thumb was, you have swelling. And swelling doesn't have to hurt you or bother you, but it's a finding that will tell you that you may have something causing your spider veins that is a little bit more than just the fact that you had 2 babies and this is part of aging. So then you're going to say, could there be a valve failure that can be treated? And the reason vascular surgeons are the expert in that disease is that we are surgeons, and the first thing we do is we try to find if there is a failed valve in the location that we can do something about to get rid of the source of the problem. So when we assess somebody, we typically will do an ultrasound, and then I can tell you either, Nancy, your spider veins are nothing, your veins are all normal, and this is part of being alive. And if you hate them, we could treat them for you for cosmetic reasons. Okay. And or if I notice some swelling that you haven't noticed, let's say, or you told me, yeah, it gets heavy as the day progresses, or it scratches me, it itches me, and I have to scratch it, etc. Then we do the ultrasound, and I could tell you, Nancy, one of your veins has pretty much terrible valves, and it's enlarged, and it's sending blood in the wrong direction. And if you have enough symptoms that bother you, we could take this vein out of commission, so we could restore the physiology in your leg to normal.
So when you're talking like purely cosmetic versus there's a medical reason and something a little bit more is going on, where does insurance kind of come into play with all this?
That's an excellent question, because that's a venous disease is a gray zone sometimes, and you could feel that any vein in my leg that's not normal is disease, but I need to get rid of it. But the insurance company or society in general, we said, well, we can't, as a society, support everybody treating every little spider vein on their leg. So in general, typically the first evaluation, insurances would cover it. It means even if you have, spider veins that you just think are unsightly and you hate them, you're disturbed enough by these findings bothering you. You tell your, family doctor, your primary care physician, can we talk about this? And if he decides to refer you to a specialist, that's very appropriate. And you get examined. We could help you determine what's to what's expected in the next few years in your leg, and then go over the options. But and then if we decide to do the ultrasound, we see if something needs to be treated. So the questions that an insurance company wants to hear to determine if they're going to say, okay, Dr. Eid, if you treat Nancy, we believe this is a part of our obligation to pay for it.
Okay.
Versus, Dr. Eid, you're going to tell Nancy this is cosmetic. So they love terms called ADLs, activities of daily living.
Yeah.
So I'm going to ask you, Nancy, okay, what do you do for a living at work? Like now, does your leg get heavy so that in your lunch break you look for 2 chairs while you're having your
Right.
lunch? You
Right.
want to sit on a chair, eat, but you want your legs up on another
Yeah.
chair so the throbbing goes away. Do you have to interrupt work to just rub your legs or raise them up?
Right.
Have you ever skipped work because your legs are too achy or hurting? Is there things that you used to be able to do before your veins started acting up that you can't do, or and that's what would guide is, are we going to treat this as a disease that we all agree deserves to be treated and society or whoever should take care of it, or whether we're going to say, well, this is a tiny issue, it's still not normal, but sort of the social contract says that if you just have spider veins with no swelling, no pain, nothing,
Right.
it's cosmetic. In that case, yes, we can treat it, but we will tell you how much it costs and how we can treat it.
I think you made an important point too, is like, we don't have to live with that. Like sometimes your tolerance increases over time and you're like, oh, this is nothing, or you get used to it, or you just figure it's normal to have to feel like you have to put your legs up. But you don't have to. Like there is treatment.
That's a great point. I mean, I see people in the office that, they have horrible venous disease, and I can't believe they're asymptomatic sometimes, but I guess it happens somewhat insidiously. So you just learn to live with those symptoms.
What you described is so much real life. Absolutely. I see patients who have a huge brown leg that's looking at me and saying, I'm going to have a skin breakdown tomorrow. But I'm seeing them because they have had a stroke and they need surgery on their carotid artery, or they have an aneurysm, or they're getting treated for a cancer, etc. And when you tell them, hey, your leg is, they say, oh, it's fine, doctor, I'm fine. But I also would be sitting with a 22-year-old school teacher who's totally
Right.
healthy, goes to the gym, and that teacher tells me, I just hate this little bulge on my leg when I'm on the treadmill. After 10 minutes, it starts throbbing.
Yeah.
So what can we do about it? So this is when we talk about how much is this affecting your quality of life, your performing your job. And when you mention insurance now, luckily society is evolving, and we are seeing more and more that the system acknowledges well-being as part of health. So the bottom line is if you have to stop doing what you're doing because your leg is throbbing, I'm not going to tell you, Nancy, that you'll never die from this. You'll never lose your leg from this, so just keep it.
Suck it up.
No, it's we don't live forever, so any day with discomfort and pain is a day lost. So if we can reverse
true.
that process for you, it makes sense to do it.
Will the insurance cover any symptomatic disease? Like you mentioned, for example, the person who has an isolated varicose vein that bothers them, it's symptomatic. Is that covered by insurance, or do they need to see more than just a complaint of symptoms to be able to pay for or compensate whatever procedure is done?
It differs on the plan you have, but in general, they do want to see symptoms. They want to see a reasonable effort to avert the problem before resorting to an intervention. For example, if you tell me I have this vein that throbs, before I tell you what kind of surgery I can do, I should tell you, you know what, Nancy, I'm going to prescribe to you support stockings. Try to wear them, and they could be very helpful. And let's meet in 3 months. If you come back in 3 months telling me Dr. Eid, I love it. I wear the stockings. They're actually pretty, and I have no pain.
Well,
We're done.
so you're laughing, but they have these support stockings on Amazon with pretty butterflies on them and everything else.
Absolutely. Yeah.
And now you have the prescription ones. Are those like the heavy duty ones that are going to work so much better?
You can start with the Amazon ones if you have mild disease,
Yeah.
but the concept is they have to be graduated support stockings. What do I mean by graduated? And that's why they're expensive. They're designed where the stockings put more pressure in the foot, slightly less in the ankle, slightly less in the lower leg, slightly
Okay.
less in the mid calf. Because if they don't do that, imagine if there's more pressure in the calf than the ankle,
Right.
then they're going to cause swelling. So that's why we care that they are graduated support stockings. And then the other thing we determine when we prescribe them is how much pressure, 15 to 25, 10 to 15, 25 to 30. And this has to do with the severity of the symptoms and can the patient do it? So when the patient asks me, okay, what pressure do you want to give? My answer is, I'm going to give you the pressure that will put these on your leg, not in the drawer in your bedroom. Because if you're going to realize that putting them on is a painful experience,
Right.
you won't use them.
Right.
So we have to find the happy medium and see if we can control your symptoms and stop them by conservative measures. If you tell me my veins hurt, let's say, when I run, but I just joined a club, I'm going to be swimming instead, and it's not bothering me, we don't need to operate on it. So remember, it's a disease that's affecting quality of life, not life itself. So I'll never tell a patient with venous insufficiency, you must have an operation. If you have gangrene, I'm going to tell you need an operation, otherwise you're going to lose your leg, and
Right.
that's a big mistake. But with venous disease, I will educate you about what it is, what you actually have. I will, to the best we can, try to give you a description of how your future will look like if we do nothing versus if we do something.
Right.
And then if
That's
we
what I wanna know.
and then if we establish a plan that includes doing a procedure, whether it's sclerotherapy or whether it's a resection of veins or whether it's closing of veins with catheter-based technologies, then we call the insurance. Okay, guys, that's the situation. Can we do it? Will you pay the bill? So that's the flow. So we always start by helping you deal with the problem and stopping it with natural ways.
Now these pretty compression stockings that I'm keeping in my bedside drawer, am I putting them on before I get up in the morning, or can I walk around a little bit? Do they have the same effect?
I can tell you're a nurse. You ask these very, very bright questions. So the answer is that's a very important question, and the reality is, the sooner you put them on in the morning, the better. So the cycle is this: if you don't put the stockings, your swelling is gonna look the best in the morning when you wake up.
Right.
Okay, and if you have, while having your coffee, reading the paper, answering some emails before you shower and go to work, your legs will already be bigger. So the idea is the earlier you can put them on when you leave the flat position to a position where your legs are on the floor, the better. So the sooner you put them on, the better. You don't need them when you're in bed.
Right.
You don't need to keep wearing them when you're in bed. So that's really the important. So there's no value trying to put them on at 4 p.m. because now I'm hurting because my leg doubled in size.
Right.
These stockings are not powerful enough to squeeze the swelling out. You need to start with no swelling, and then the stockings will make it less likely you're going to swell, or if you swell, you're going to swell less. Now, there are some conditions where we cannot do much. So somebody has, severe swelling, they have liver disease or something that I can't operate on to solve the problem for them.
Right.
And the stockings do nothing. Well, we get them special pumps, the pumps that actually you wrap around the foot and the lower leg, hook it up to electric, and it will give you a vigorous massage for an hour in the morning before you leave your bed to squeeze more fluid out of your leg before you put the stockings. So there are a lot of tricks we can go over with you. to try to make your leg ready for the stockings and make the stockings do their job the best.
So I'm going to back up a little. Oh, did you have a question you want to ask?
Go ahead,
before I
Nancy.
talk
You go
about it?
ahead.
Thank you. So I'm going to back up a little bit. So these like little spider veins that I may or may not have on my legs, like what, and the treatments that you have for this, does it hurt? How long does it take? Afterwards, am I in pain? Does it go away forever? Or
So when we're talking about the cosmetic part,
yes, we'll
we
start there.
it starts by looking at them and having a realistic expectation of what we can achieve. So first, how do we treat them? Okay, there's the two major ways for spider veins are sclerotherapy or laser,
Okay.
and they're pretty much equivalent. We used to have a laser for a few years. Now we're doing sclerotherapy.
What exactly is sclerotherapy?
Sclerotherapy is a process where I will wear surgical loops, and I will put a material that's corrosive, that can injure the vein, in a needle, and I will use a extremely small needle, 32
Sounds like a
gauge.
Sopranos episode.
Why?
It sounds like a Sopranos episode. I'm going to inject this into you.
You'll be fine.
So yeah, it's a bad material if you inject it in the wrong place.
Yeah, I would
So
think.
yeah, so it's technically like a chemical injury of the inside of the vein. So what we do is we inject that material inside the spider,
Okay.
and that will injure the walls of that vein, and then we put some pressure on it for a few minutes, hoping that it's gonna close, the seal on itself. Now, in real life, whatever you do, that vein, when you injure it with the material you inject, is gonna clot. It's gonna close. It's gonna go away. But that process is not something we do. That process your body will do.
Okay.
The best I can do is to injure that vein with the injection and put some pressure on it for, usually minutes, and to try to make that process happen with the vein either empty or having the least amount of blood in it that's possible. This is never 100% exact.
Sure.
You can't achieve 100% of that. But so what you're left with is your body absorbing that injured vein.
Okay.
So that process is usually good, but isn't perfect. So we will educate you that if we do sclerotherapy, there are some things that can happen. Number one, you may have a reaction where your tissues perceive of this as an injury, because it is an injury, it's a controlled injury, and they will form some scar tissue which could cause darkening of the skin. So dark spots are something we tell you about before we do sclerotherapy. Depends on the material we use, we could cause a blister in the skin. We wear surgical loops, we use 32 gauge needles, but sometimes the material leaks outside the vein we inject and could injure the tissues enough that it could cause a blister in the skin, which typically goes away with no traces, but it can leave a trace. Other complications, or not really complications, but things you should know about, is a process called neovascularization. So the way I describe it, I say your cells don't know that we're friends. So when I inject this, they're going to react to this as an injury, and your cells will say, oh my God, this vein closed. Let's make new veins. And the veins they make are going to be tiny, even smaller than the one we treated, and they're going to be tougher to treat. So while the vein that bothered you will go away, you could, if you look carefully, sometimes you're going to find, oh, there's now new veins that are much smaller, but they're there. So it's not magic. So it is definitely a game of expectation. If somebody comes to me with their legs looking like they're full of spider veins, I will tell them, number one, you probably need a lot of treatments. Number two, I am very confident I'm going to make you better, but I cannot be sure I can make your legs look like you've never had this problem. Now, if you have somebody who comes with 3 veins and otherwise they're fit and perfect shape, I educate them even more, because I tell them with 3 veins, all it takes is one dark spot, and you're going to say, why did I do this? So it's all a game of
Right.
where are you now and what can you reach and is it worth it for you?
Right.
You know,
Doctor, the ropey varicose veins, can you ever make those disappear entirely?
rope. What do you mean by rope?
Like the ones that look like fingers going up,
Yes.
twisting up your leg.
Absolutely. If you have veins that you can feel by hand, you should always get a workup. Means that justifies an ultrasound. Even if you have no symptoms, at least to know what's happening.
Okay.
Because the ultrasound, if you have ropey veins, veins that are big, you deserve to know what's the likelihood of this becoming worse in 2-3 years or in 6 months or whatever. What's the chance I'm going to have a blood clot? What's it? So that becomes medical. A big vein that you could close your eyes and feel by hand and say,
Right.
oops, there's a lump here.
Right.
That's always worth some investigation.
Okay.
Most of them could be benign, but it's worth knowing what's happening, especially if you're still in the productive years. I mean, I'm not saying this for people looking at their 90-year-old grandma's leg and saying,
Right.
"Oh my God, there's a vein," But if you're a functioning, reasonably active person with a reasonable health, having a bulging vein is not normal, and it's worth knowing what's going on.
So what's
So-
the? I'm sorry. Go ahead.
That's okay. So we talked about some of the cosmetic issues with spider veins, and we've kind of moved now into some of the larger vein issues. So what do you do about those larger vein issues? What's the treatment?
Well, the treatment hinges on what we're going to find on an ultrasound. We do an ultrasound that will, number one, determine do you have enlarged veins because they're doing their best to compensate for other veins that have clotted. If there's if you come to me and you tell me there's big dilated veins on my calf or on my thigh, but you just also tell me that 6 months ago I was skiing, I broke my leg, and I was in a cast for 6 weeks.
Right.
You may have had a blood clot in your deep veins that was not noticed and luckily didn't kill you, and that your superficial veins now are dilating to try to do the job of the deep vein that's clotted, is gone. So the ultrasound will tell me that. So then we're going to say, okay, do you have varicose veins as a result of something else, or is it a primary valve failure? So ultrasound will give me that answer.
Okay.
And typically, the ultrasound will also map your dilated veins to a vein that has bad valves. If that vein is a superficial vein, we typically need to close it for you. That in the past, it used to be called vein stripping, where we actually give you anesthesia, we make little incisions, and we take the vein out. Today, we do it in the office. We go in with a catheter, and we could glue that vein shut, believe it or not, or we could cauterize it. Depends on what technology your doctor has or what your insurance plan covers. So we look for what's causing that vein to be dilated and to be a varicose vein, and we close it.
Okay.
And at the same time, depends on the situation, we could sometimes remove that ropey vein. We remove what caused it, but we could also take it out itself. Or sometimes we would tell you, if you give it a few weeks, believe it or not, this vein will shrink and go away.
Okay. So I'm going to ask you a question that I bet some of our viewers are wondering right now. So if you have a diseased vein, a varicose vein, and you go in and you close that vein, does that put more pressure and stress on the rest of the venous system in that extremity?
Shouldn't, because what happens is if a vein is failed, that it's leaving blood behind below the failure. That vein is going to go and stress, that extra blood is going to stress more veins and more valves below it, and they're going to fail. So if you remove the vein that has failed valves, you're actually improving the physiology. The veins will handle the flow if it's normal. If there's no pooling that's artificial related to one failed valve, they do better. As a matter of fact, if you have in some patients, like when I discuss doing a vein, we call these vein ablation, means to close a major superficial vein. And patients want to know, okay, doctor, you're going to do this procedure on me, like how likely is the problem going to come back? Okay, so we relate that also to the ultrasound. Sometimes I'll tell them, the vein I'm going to remove is the only abnormal vein in your leg. So you fall in the best category. It means it's very high likelihood that you're going to be very happy with the results. But sometimes if I find that the valves have failed in the vein that I can remove, but they've also failed in the deep veins, which I cannot remove, I'm going to tell that patient a different story. I'm going to tell them there's a good chance you're going to feel better. I probably will remove the bulging veins in case the deep veins would feed them with blood and keep them bothersome. But I can't for sure tell that you're going to be completely symptom-free because I am leaving you with some failed valves in veins that I cannot remove. You need your deep veins. So the ultrasound will help you predict what's going to happen, how likely is a procedure going to be successful. Across the board, up to 20% of patients who will have a procedure done on veins will have another one.
Oh.
Okay.
Can I ask you another question too? I have like a 0 pain tolerance. I'm a baby when it comes to pain. How uncomfortable are these procedures?
We've done thousands under local anesthesia. So, I mean, some people could be more sensitive, but maybe twice a year we prescribe like Valium or something before the procedure to a patient. Maybe once a year, a patient looking back tells me, doctor, I wish you gave me Valium. I did not have a good experience with this. But by and large, most patients will describe it as very feasible. And
Nice.
as a matter of fact, this is often a bilateral leg.
Yes.
I've almost never had a patient, let's say, who's done the right leg, telling me, based on the right leg, I don't want to do the left leg.
Right.
Most of them will come back for the left leg and get it
That's
done.
great.
Yeah.
Okay. A lot of patients have, had a history of, say, blood clots and we call DVTs, of course. That damages the veins, I'm assuming.
Big time.
Right.
Absolutely.
So this is now in a deep vein and you have a damaged deep vein. What can you do about that?
That is an unbelievable question because I hope many physicians hear this because physicians are also sometimes dismissive of this. The interventional world now has advanced so much that we can address things like this. So when you have a DVT, when your major deep veins have clotted, number one, this usually happens for people who in general are at a sicker level as citizens, as humans, So they tend to have other medical problems. And when we address them, it is much more involved and serious situation, so we give it a lot of attention. So there is a syndrome, a condition called post-phlebitic syndrome, means after a clot syndrome.
Okay.
And that includes swelling, brown disco, everything we've talked about on steroids. You could have, your leg will be huge, you could have ulcers in the skin within a year or whatever. So the first question is, nowadays, if you have a blood clot, if you have a DVT, okay, you should not have the reflex of saying, we just give these patients a blood thinner. So the first thing to prevent these now is to start thinking when you face a patient with a DVT as a physician, okay, which one of these patients could benefit from having the clot removed? Because typically for generations, we treated DVTs by blood thinners, by saying we're going to thin the blood, and the patients will not die from it. The DVTs kill you by sending a clot to your heart and lungs. The blood thinners achieve this protection at a very high rate of certainty within hours, literally. This is why now you treat DVTs in the outpatient setting.
Right.
You don't put them in the hospital anymore. They take the pill within 1 hour, they're safe.
And it always used to be a hospitalization
Yes,
type
exactly.
issue. It's interesting.
So
It's changed.
So the question is, which patients could benefit from having the clots taken out? So in general, the higher the clot, the more likely there's going to be a benefit in taking it out. simply because the higher veins control more veins below them. So, and how can you see that? Sometimes the radiologist reading the study is not in tune to treatment. He's more in tune to say there's a clot. And again, traditionally, they sort of don't care where the clot is because you're going to just give all of these people blood thinners. So the report now can fool you or may miss giving you crucial information. So there are some veins, if you don't want to shop too much with technical terms, but if it's common femoral vein or iliac vein, like higher up veins, these almost always deserve a conversation with an expert who could perform clot extraction. So if you have a clot that is at or above the groin, they always deserve to answer the question, should I take that clot out? We don't always take it out, but the patient deserves that question addressed. Below that point, it becomes controversial. So the clot in the thigh, there's much less evidence that it's a good idea to remove it, so we individualize. So and if the patient is young and healthy and otherwise no issue, we sometimes discuss removing the clot with the disclaimer that I don't know if that's going to make a big difference for you. Now, clinically, if you want to take before the ultrasound, when do I worry? Well, if the swelling is just at the ankle and is mild, I don't want to have an invasive procedure to remove that clot because it's probably a benign clot. If the calf is swollen, it's in between. If the thigh is swollen, I think this patient deserves a formal consultation by somebody who could remove the clot.
That's a good way to look at it.
Yes, clinically, in your office, somebody comes and there is you suspect a clot. And you're going to send them for an ultrasound. You know you're going to get the result at 5 p.m. So if the patient has some swollen ankle as your indication, you're going to tell him, I may call in a blood thinner prescription when they call me with the result of your ultrasound. If the entire leg is swollen, you're going to tell that patient, when I get the result of that ultrasound, I may ask you to go to the hospital. So it all depends on what you're seeing.
And I think it's important for the audience to understand that the blood thinners that we use, they don't necessarily break up the blood clot. They prevent it from propagating.
That's a great
they
point.
reduce the risk of a pulmonary embolism, but that clot is dealt with through the body's own mechanism in a different way. So I guess that's why it's important with a significant burden of blood clot that we look at these other modalities to treat it.
Absolutely.
Dr. Eid, so say someone like a year ago had a DVT that was complicated with pulmonary emboli, they were put on blood thinners. Like now, should they just follow up with you or go to you like a year later if they're going to maintain?
Another excellent question. Absolutely. So if somebody has a DVT and you had a PE, means it went to the lung, and we're a year later, okay, if the DVT was minor and the patient feels fine, then no. There's guidelines on how long to give the blood thinners for, etc. You just follow them. However, if the patient is affected with quality of life affecting symptoms, what the post-phlebitic syndrome, the answer is absolutely we can see them. And again, while I stressed the high efficiency of immediate interventions to remove clot, we're less effective a year later, but there are things we can do still. So one example that's definitely justified is if the clot happened above the groin, which is the one that can more likely to cause a post-phlebitic syndrome. If the clot is above the groin, even a year later, I can't take the clot anymore because the clot always starts looking like jello.
Yeah.
But after weeks, it becomes like the pencil eraser. It becomes like thick rubber. So you can't dissolve that anymore. You can't suck it out with a device that has suction. However, you could go through it with a wire, and then you could stretch that vein with a balloon, and you could put a stent to leave the vein open now. So if the patient's leg is swollen because the iliac vein, which is the vein above the groin, has clotted a year ago, I could potentially, and it doesn't always work obviously, but I could potentially go through that blockage, that occlusion, with a wire and balloon the vein to stretch it. And if it keeps recoiling and closing, I'll put a stent in it that will keep it open and have you on the blood thinner to protect that stent and keep it open. And that usually produces very good results. Patients will be very happy. The throbbing, the pain, the heaviness improves a lot.
Thank you.
So venous insufficiency ulcers, these ulcers that some patients get as a hallmark of their venous disease, that's a really frustrating problem to deal with.
Yes.
And we could probably do a whole podcast on that alone, but how do you deal with those types of issues? What is the general approach?
Number one, and this is guidelines that were published recently, we used to try to heal them, then figure out, do I need to close a vein or put a stent or whatever?
Right.
But the high failure rate of treating these ulcers flipped the recommendation. So now the recommendation is you should immediately find a fixable anatomy and fix it. So if a vein has bad valves, we should immediately close that vein with the glue or with the radio frequency, whatever technology we use, and then the ulcer will have a much better chances of healing. This is number one. Number two, you treat the ulcer like an ulcer means it has to be clean. You educate the patient about it, and I have to say we have excellent wound care centers. So while we can take care of these, in the office setting, but sometimes we send them to a wound care center. Depends on the patient's situation. Some of them, if the ulcer is not major, we could take care of them in the office. But if they need, let's say, twice a week visits and stuff, we could refer them to a wound care center.
Nice.
But the message is, if you have a venous ulcer, which is typically, an ulcer in the skin that's brownish, scarred down, typically in the lower leg above the ankle on the inner side, or any variation of that. These always deserve an aggressive workup by a vascular specialist to see if you can improve the anatomy to make it heal faster. I've seen ulcers that were open for a year and going to a wound care center, getting very good care. And then somebody thought, maybe we'll have a vascular surgeon see them. And we study them, and indeed, their superficial vein is huge, has no valves at all. You close that vein, and in 2 weeks, the ulcer is healed, literally. So they need a workup, absolutely.
Okay. So that's an important point. That's fairly new information, I think, too, right? About...
This is recent guidelines, not like months, but a few years, yeah.
Yeah, because I haven't really seen that done a lot, but it makes perfect, absolute sense. And I see a lot of patients, I've seen a lot over the years who've had they've really struggled with these ulcers. And it's good to know that there's other things that they can do to try to improve the healing of them.
Yes. I'd like to highlight one point, which is the importance of an accredited vein center.
Yes.
So while any licensed physician can take care of you for any problem, vein problems are a multi-system problems. And they are under scrutiny because of that gray zone between what's cosmetic and what's not cosmetic.
Right.
And also they are under scrutiny because there's a lot of procedures of unknown value that actually pay well, and some people like to do them. So there is now the concept of accreditation of vein centers. So our center is accredited, and to get that accreditation requires actually, number one, being in a registry, submitting your data, your results, your policy and procedures. How do you do these surgeries? How do you screen for the disease? Is your ultrasound reliable? It's when we say you have a bad valve, in what % of the times could your test be wrong, etc. So all this process gets scrutinized by the accrediting body, and then you get an accreditation as a vein center. I am a board-certified vascular surgeon, but my environment, my nurse, my X-ray tech, my nurse practitioner, my physician assistants, all of these are involved in a process how to handle this patient. So many patients, I meet them for the first time the day of the procedure. They see staff in my office who are as knowledgeable as I am. The only thing they don't do is the actual operation. But they know how to work the patient up. They know how to do the test. They know how to interpret the test. They will counsel the patient about the choices they have, how to pick what therapy. Do I need to close the vein and resect other veins? Is it enough to just close the vein and wait it out? When do we give you a blood thinner? So all of this is governed by a lot of processes. And it's good to go to a place that has gone through the effort to put all this package together and get an accreditation as an accredited vein center.
That's an excellent point. And as someone who has firsthand seen your Center for Excellence, I've never seen another place that even comes close to matching it. So you should be super proud of what you've built. And can you just give us that contact information again and the location and how they get in touch with you, Dr. Eid?
We have a website, Center for Vascular Diseases. We have now a different website, Vein Clinic, the Vein Center,
Nice.
which is part of our, our big practice. But we're on 901 South Main Street. We're in Taunton, across from the hospital in Taunton. We're also in Johnston, Rhode Island. We're very soon are going to be in Attleboro in the professional building of Sturdy Memorial Hospital. And we're actually building a pretty large vascular center in North Providence.
So much growth. That's great.
So we'll get all that posted as far as the contact information. If you can give that to us later on, we'll get it out to our viewers.
Love to.
That'd be great. Thank you.
Thank you very much.
Thank you, Dr. Eid.
So I think we're getting towards the end now.
Yes,
So
I would say.
as we close, is there anything you want to leave our audience with as far as recommendations, or just as maybe put everything in a nutshell for them?
I think what we talked about fall under one item, which affects every human, especially as you could see 2 out of 3 people here have gray hair, is
Mine's died.
yes.
Sorry.
Okay, you didn't
3
have
out
to
of
say
3.
that. So yeah, it's 3 out of 3.
My ask for every person in my community is healthy living. Eat healthy. Don't eat a lot. I'm trying. Exercise. Walk if you can. If you can avoid driving and walking, do it. Eat more salads. Eat less steak. Healthy living. It will keep you out of the hands of people who do operations, and it will, this is why we're renaming our Center of Vascular Wellness. I would love to come back in this lovely setting and talk about what's coming in terms of vascular wellness. We will be able to, we're changing how we treat vascular disease from saying you have a problem and today you don't need an operation. I'm going to check you every 6 months. So when you need the operation, I'll do it. We're going to change from saying, you don't need an operation today, but let's sit down and talk about how we can make you never need that operation. Mm-hmm. That's going to be the transition into vascular wellness. And believe it or not, most of it is not medications. Most of it is working with you on how you live every day. And we will make that transition. You're going to see treadmills in our office.
You know what? I was just going to say, what would be cool for next time, Dr. Eid, is when you rebrand and you're all set and you're ready to go, to do a tour of the facility, and you can just talk.
Do that.
Yeah, that would be awesome. So people could actually see, the facility and what your place looks like. And
we'll be honored to do that.
Yeah.
Well, I want to thank you for coming on the podcast and providing such great information for our viewers. This was a really, great podcast. As expected, you did a great job last time.
It's always my pleasure to be with you guys, and you have actually helped make our practice better. Nancy lived with us for maybe 2 months and analyzed everything we do, and that was unbelievably helpful for us.
That's great to hear. Thank you. And I want to thank Bakos Bank. Bakos Bank is just right for all of your financial needs. Visit bakos.bank or call 508-678-7641 to learn more. So thank you very much for watching the 27th Degree with Chris and Nancy from 27 Degrees Consulting. And thank you, Dr. Eid, once again. And we'll catch up with you all again in another week or so. Take care.
Thanks.